Good evening, sir. Just, I'm not able to hear you. I think you are muted, sir. Kindly unmute.
Okay, that should work. Can you hear me now?
Yes, sir. Thank you so much. Once again, it's a honor. We are only feeling bad that you are not here physically with us.
Yeah.
But it's so nice. It's so nice of you to join today. Today is the final day of our 4-day Congress. We had a lot of sessions, a lot of the dignitaries. Now we are again blessed to have you also. So nice of you.
Well, thank you.
So time now here is people are joining only 8:22. 8:30 is the time we set. So another 7-8 minutes we'll go live, sir, if that is okay.
Okay. So I have a half hour.
Yes, sir. Half an hour for the lecture, and then another 15 minutes for discussion. So
okay.
Professor Binu Nainan, another neonatologist from India, from southern India, Chennai, will be the moderator for the session. You will see him when he joins. And then Dr. Minu, you want to come? I'll just, he is here, but we are not gone live. Live, the stage is.
Sure.
I think people are joining.
Good morning.
Good morning. Oh, good evening. Good morning.
Yeah, it is evening there.
Yeah.
Rather, we should say night, isn't it, sir?
Yes.
Good evening.
Yeah. What time is it there, sir?
It's almost 11 o'clock.
Oh my God. I'm so sorry. Yeah. Sincere apologies to keep
no problem. No problem.
Like, because if you keep it at other times, no, like people will not join. No? We want this is a time in India. Like,
sure. Sure.
Also, Peter Davis is here, and he was he was in person here actually. So
oh wow!
Probably if he joins, then in between after the session, I will turn the camera to him. I don't know. There is another session. That's a record. Professor Alan Job's talk is there at 9 o'clock after this. Immediately after this. So I don't know where he'll be listening at that time actually. So.
Yeah.
We are having.
Is there a way? Is there a way I can test the screen to make sure that my PowerPoint?
Yes, I will tell. I will hand over to my technical team, and then we will start testing right away, sir.
Okay.
Thank you. Thank you so much once again. I'll write you, sir, after this.
Very welcome. Okay.
Thank you, sir. Just we'll put it live and see. Yeah. No, he wants to share it and see. Yeah. So you want to share the screen, sir? Please.
Yeah, I just want to make sure that it works.
Yeah. Please go ahead, sir. Perfect. Perfect, sir. It's working perfectly.
Good. Good. Okay. Very good.
Good morning. Good morning, everyone. Good morning, Dr. Joseph New.
Morning.
And it's indeed a great pleasure to introduce Dr. New this morning for this talk on controversies in the nutrition of ELBW patients and babies. Dr. New is Professor, Department of Pediatrics, Division of Neonatology. He received his bachelor's and arts degree in 1971 at Wisconsin State University and completed his pediatric residency at Johns Hopkins Hospital, Baltimore. MD from 1975 to 1978 and 1978 to 1980 did a postdoctoral fellow in neonatology from the Stanford University. In 1987, he completed a sabbatical from Switzerland. Dr. New has received during his career several honors and awards. He chairs and is involved on national and international committees. Dr. New is active on several societal memberships, editorial boards, journal reviewer, service to the community, service to schools. He is well known for his lectures here and abroad. Dr. New has received many appointments as assistant professor, director, division of neonatology, associate professor, a huge list. I think probably at this stage, he is now currently the director of the Neonatal Intensive Care Unit at the University of Florida. His interest in teaching and research is in nutrition and the GI environment. It is indeed a great pleasure to welcome him to this morning conference, and we are looking forward for the next 30 minutes for his lecture on the controversies in the nutrition of ELBW babies. At the end of 30 minutes, we will have 15 minutes for discussion and any clarifications you would like. Dr. New, you could probably start now.
I'd like to start with thanking everybody for this very kind introduction, and also for inviting me to this conference. Unfortunately, we can't be there in person. I think that you have done a wonderful job in terms of putting together this exciting 4-day conference, and I'm just very pleased that you're able to accomplish this very challenging task. So let me just see if you can see my screen, right? Okay, so I'll be talking the next half hour about some controversies in nutrition of the extremely low birth weight infant. This is a topic that is very broad, and I think it's very difficult to do justice to this area in just 1/2 hour. But I will try to pick out some areas that I think are of major interest to many of us, and we'll just focus on some of those areas. So let's start here, and here's a picture of a 27-week preterm baby. And the question is, how do we nourish this baby? And the agenda for the next 30 minutes will be, I want to talk a little bit about the nutritional emergency.
Sorry to interrupt, Dr. New, but
Yes.
the slides are not seen.
Oh, the slides are not seen. Okay, because I see them here. Let me. Okay, let's go ahead with starting screen again. And
yeah, now we can see. Yes, we can see the screen now. Yes, we can.
Beginning.
Yeah.
Okay.
Yeah, you can go ahead now. Thank you.
Now, let's make sure that we are seeing the same screen.
Yeah, this is this is a growth chart that you're showing now.
Yes. Okay. Okay. So here is the agenda for today. I will talk a bit about the nutritional emergency of the low birth weight preterm infants. Talk about some of the consequences of early undernutrition, and then I'm going to focus on some of the controversies, and these will include intravenous lipids, then enteral feeding, how much advancement, holding feedings during endomethacin and therapeutic hypothermia, checking gastric residuals, and then also I want to talk a bit about personalized nutrition and where we are going in the future. So here's a typical growth chart and a picture of Richard Ehrenkrantz, a colleague at Yale University that I had worked with in the area of neonatal nutrition. And he devised this growth curve where we see the fetal growth from the 10th week, from babies that are in the 10th percentile and percentile for fetal growth. But those babies who are born before 25 weeks, 26, 27 weeks, and 28, 29 weeks, you can see that these babies lag behind. And this is very unfortunate because this is frequently associated with some real problems after the babies get out of the neonatal intensive care unit, as well as having some problems within the neonatal intensive care unit. We see numerous adverse effects associated with poor growth. Now, when we talk about fetal nutrition, we see that these babies in utero have a continuous supply of glucose. Protein is taken up at around 4 grams per kilogram per day, and lipids at 3 grams per kilogram per day. When the baby is born preterm, this is interrupted. And this could be highly problematic. This interruption could be highly problematic. Why? Well, here we look at what a fetus looks like in utero in terms of body composition and energy stores. So here's 24 weeks gestation, 26, 28, and 40 weeks gestation. And here we see the weight, the water composition, protein, lipid, and energy store. So a baby that's born between 24 and 26 weeks gestation has very low energy stores. This kind of an energy store, 123 calories per kilo per day, is what this baby needs in one day for survival. If the baby does not get this energy, what begins to happen is that this baby begins to utilize protein from its own body in terms of proteolysis, in terms of energy, to be able to produce energy. And that will not last long. So this is a real problem in these very low birth weight infants. And we have to consider this an emergency, just like we do many other emergencies short of birth. So what are the requirements in most of our babies? There are 100 kilogram per day growth if the baby is fed enterally. If the baby is on total parenteral nutrition, we can attain positive nutrition balance, 60 calories per kilogram a day, with about 0.5 grams per kilogram per day of protein. Minimal caloric intake for weight gain is about 80 calories per kilogram per day if on TPN. So this is important to remember that TPN and enteral nutrition require different caloric intakes, but they are still highly significant and highly important in terms of this baby's survival and subsequent outcome. Now, when we think about this in terms of how much energy this little preterm baby is getting in terms of what the adult would be getting, if this baby is requiring 120 calories per kilogram per day, this equates to this guy here who is doing the Tour de France. The Tour de France cyclist is getting about 7,000 calories per kilogram per day. If you assume that he weighs 60 kilograms and is getting 120 calories per kilogram per day, that is similar to the requirement for this very low birth weight baby. So what happens at 18 months if you have a retrospective study of babies that may have been undernourished? So here is a slide that shows the first week amino acid intake. And this is the mental development index at 18 months. So during the first week after birth, for every 1 gram per kilo per day of protein increment, these babies get an 8.2 point increment in mental development index. When it comes to energy, for every 10 calories per kilogram per day at 18 months, there's about a 4.6 increment in the MDI, mental development index, at 18 months. So during this first week after birth, you can see that there is a major effect on energy and protein. Now, what are some of the problems that we have with lipid intake? Well, if a baby is getting total parenteral nutrition, classically, there's been major concern about hyperbilirubinemia, sepsis, pulmonary hypertension, lung disease, liver disease, and thrombocytopenia associated with lipid intake. All of these have been shown not to be based on evidence. And so I think that we need to get away from some of these excuses that we use to withhold lipids early on. What happens when we withhold lipids to babies? Well, this is very problematic. We need to provide around 2.5 to 3 grams per kilogram per day to try to match the in utero supply of lipid, as I mentioned before. We have essential fatty acid deficiency that occurs very rapidly if we provide lipid-free nutrition to these babies. And we also have to be giving them long-chain polyunsaturated fatty acids because many of these babies are not able to synthesize these long-chain polyunsaturated fatty acids from the shorter essential fatty acids. And these long-chain polyunsaturated fatty acids are very important in brain and retinal development. And lipids are also very important in producing energy. And if you provide enough energy, you can prevent catabolism and spare protein. Now, what about the essential fatty acids? There are 2 essential fatty acids. One is linoleic acid and the other is linolenic acid. The linoleic acid is an omega-6 fatty acid, and this is the precursor to arachidonic acid, a C20 fatty acid. Very important for growth. Linolenic acid is also an 18-carbon fatty acid that is an omega-3. And this desaturates and elongates to a 22 and 24 carbon fatty acid. The 22 carbon fatty acid is called DHA, or docosahexaenoic acid. Also very important in terms of brain development. Deficiency of these 2 essential fatty acids occurs very rapidly. And in 80% of preterms, it will occur after less than 1 week of lipid-free nutrition. And here at the right, we see what it looks like when these babies get the dermatitis associated with essential fatty acid deficiencies. And just imagine what is going on in the brain of these babies when they are not receiving these essential fatty acids. Now, lipid is a very important source of energy. And as I mentioned before, if a baby is on TPN, that baby needs 80 calories per kilogram per day for growth. And if a baby is getting 8 milligrams per kilogram per minute of glucose, that will supply 39 calories. And if that same baby is getting 3 grams per kilogram per day of amino acid, that will supply an additional 12 calories. But this baby still needs around 30 calories for 80 total. So that calculates to about 3 grams per kilo per day. And this is what we recommend starting in terms of lipids very early and after birth. There have been dogmas that we have been concerned about giving this quantity of lipid, the 3 grams per kilogram per day in the first day after birth, but there is no evidence to support that it is disadvantageous for the baby to do so. And we think that to provide this kind of energy is certainly going to be advantageous for the baby. Now, here's a controversy. When to start lipids, and what about monitoring lipids? There are many neonatologists who will monitor triglyceride levels on a daily, every other day basis very frequently. And that takes a lot of blood to monitor triglyceride levels. But we have found that prolonged infusions of lipids are safe if we give them at less than 0.2 grams per kilogram per hour. It is unusual to see hypertriglyceridemia, although some extremely small babies may develop hypertriglyceridemia, the harm that that will do is very well, is not very well substantiated. We do not have good norms for monitoring triglycerides. There are different norms that are recommended in different textbooks, but none of these are evidence-based. And so because of this, many of us, including me and our neonatal intensive care unit at the University of Florida, have stopped doing routine measurements of triglycerides in our very low birth weight babies. Now, what about enteral feedings? We have many excuses to withhold enteral feedings. And why do we have these excuses? We are all very concerned that we are going to cause necrotizing enterocolitis. So traditionally, we've withheld enteral feedings in babies with low APGAR scores, babies who have umbilical catheters, who have apnea and bradycardia, who are receiving mechanical ventilation, CPAP, or vasoactive drugs. And we have this concept that TPN is available and we can just nourish babies with TPN for prolonged periods of time. But this is problematic. And again, none of these excuses to withhold enteral feedings are evidence-based. Now, here's a picture of a lady from the UK. This is Dr. Elsie Widdowson. And around 60 years ago, she did some very important studies on piglets, where she found that in the first 24 hours after birth, the suckled pig's duodenum gains about 42% of its weight. This is what is called a trophic effect of enteral feeding. If you do not enterally feed a piglet like this, the intestine does not gain weight. This has been seen in numerous studies in animals, that you have to provide enteral nutrition for this trophic effect to occur. Parenteral nutrition will not provide this. In the mid-1980s, Dr. Alan Lucas and colleagues did some work looking at the plasma gastrointestinal hormones in premature infants. And he looked at 5 different gastrointestinal hormones: enteroglucagon, gastrin, GIP, motilin, and neurotensin. And at birth, we see this level of these hormones. At 6 days, if the baby is not fed at 6 days, these hormones do not rise. If the baby is fed and is well, you can see that at 6 days, these hormones rise dramatically. And even if the baby has respiratory distress syndrome, these hormones rise very significantly. So in order to have this hormonal response, which is important for gut motility, for breaking down various nutrients in the gastrointestinal tract, for insulin production, it's very important that we put some food into the gastrointestinal tract. What happens to the liver if food is not provided and just parenteral nutrition is given? Well, here on the left, we see a liver after 7 days of enteral nutrition. And on the right, we see a liver after 7 days of TPN. And you can see, just grossly looking at the liver, that the TPN liver is very pale compared to the enterally nourished liver. And on H&E stain, you see ballooning of the hepatocytes. And you see fat staining in the liver that is getting parenteral nutrition, and also glycogen staining. So we are actually harming the liver by not providing enteral nutrition. This is a slide that shows what happens to the gut permeability at 15 days after birth if food is not provided in the gastrointestinal tract of preterm babies. And this study was done in the late 1990s by Drs. Shulman and Chandler. And what they did in this study was they had two groups of babies. One group was getting gastrointestinal priming, so small amounts of feeding in the gastrointestinal tract, and the other group was getting total parenteral nutrition to day 15. And they provided these babies with lactulose and mannitol. They measured the lactulose and mannitol as permeability markers in the bloodstream of these babies. And here we see in the blue those babies who were getting TPN. And here in the gray, we see the babies that were getting GI priming. So the permeability was much higher in the babies who were getting TPN. And this means that the junctions between epithelial cells were more open in those babies who were getting only TPN and having no food in their gastrointestinal tract. And this could potentially lead to higher permeability and mucosal antigens getting through to a highly inflammatory submucosa that can cause intestinal inflammation. So having food in the gastrointestinal tract can actually decrease intestinal inflammation. And here's a study that seems to support that. This is a study that was done by Dr. Liza Konnikova at Harvard University and published about 6-7 years ago. And they had two groups that they evaluated observationally, retrospectively. One group was fed early, prior to 4 days, enterally, and the other group was fed after 4 days. And here we see some of the adverse outcomes in the early fed group compared to the late fed group. The late fed group had significantly higher adverse outcomes, such as retinopathy of prematurity, chronic lung disease, periventricular leukomalacia. And at 2 weeks after birth, this late fed group also had higher interleukin-8 and other pro-inflammatory mediators in the bloodstream, suggesting that the early feeding prevented the inflammatory response in these babies. What about rate of enteral nutrition advancement? This is a study that was just published a couple of years ago from the UK in the New England Journal of Medicine. And the title of this paper was Controlled Trial of 2 Incremental Milk Feeding Rates in Preterm Infants. One of the incremental rates was 18 cc's per kilo per day, and the other was 30 cc's per kilo per day. And what they showed in this study was that there was no significant difference in survival of these two groups, and no significant difference in terms of sepsis or advertising enterocolitis in these two groups of babies, despite one having a very aggressive rate of enteral feeding increase. Now, here's some further controversies, and I just want to ask you some questions here. Do you keep feeding if you are giving indomethacin for ductus arteriosus? Do you keep feeding if you're giving indomethacin for IVH prophylaxis? What about hypothermia for hypoxic ischemic encephalopathy? Do you routinely check gastric residuals? Do you routinely use suppositories in these preterm babies? Let's start out with this concept. This was a study that was done at Baylor University in the early 2000s. And what they did in this was they looked at piglet superior mesenteric artery blood flow during 2 epochs. One was an epoch where the babies were, where these animals were getting enteral nutrition, another where they were getting TPN. And here you can see the superior mesenteric artery blood flow was considerably higher when these babies were getting enteral nutrition compared to when they were getting TPN. Now, what is the concern with giving indomethacin to these preterm babies? Well, the concern that we hear the most is that it causes vasoconstriction. Well, here we're seeing that lack of feeding and TPN is actually causing mesenteric vasoconstriction. So you can actually make the situation worse by not feeding the baby, and giving the indomethacin. So most neonatal intensive care units have gone away from this, especially after this study that was done by Kleiman and colleagues. And this was a multi-center study, and the title of this was Enteral Feeding During Indomethacin and Ibuprofen Treatment of a Patent Ductus Arteriosus. What this study showed was that infants required less time to reach feeding volume endpoint if they were given trophic enteral feedings when they received indomethacin or ibuprofen treatment. And again, giving feedings during indomethacin or ibuprofen treatment did not result in increased necrotizing enterocolitis in these babies. What about feeding during hypoxic ischemic encephalopathy and therapeutic hypothermia? Well, several years ago, it was dogma not to feed these babies enterally for those 3 days when these babies were getting hypoxic, when they were getting hypothermia for hypoxic ischemic encephalopathy. Well, practices were different in different countries, and in Scandinavia, they fed these babies, and in the UK, they did not feed these babies. And a paper was written looking at comparisons, and this was a paper in Acta Pediatrica Scandinavia in 2015, showing that really there were no differences in terms of inflammatory responses or necrotizing enterocolitis if these babies were actually being fed. We did a study at the University of Florida, and this was published in Neonatology in 2018. And the title of this was Enteral Feeding as an Adjunct to Hypothermia in Neonates with Hypoxic Ischemic Encephalopathy. And the results are seen on this slide. Minimal enteral nutrition subjects, this was during hypothermia for HIE. These infants had a reduced length of hospital stay. Minimal enteral nutrition was associated with less days receiving parenteral nutrition and time to full oral feedings. Minimal enteral nutrition was associated with a significantly reduced serum IL-12 at 24 and 96 hours. So we saw a decreased inflammatory response. And the brain MRI scores were not significantly different between these groups. So we have started to routinely provide some, at least minimal enteral nutrition to these infants during hypothermia. Here's the question. Here you have this little 27-week preterm baby that I showed you before, and you're on call at 2 o'clock in the morning. And the nurse reports that this baby was being fed 2 milliliters of breast milk every 3 hours, is having 2 cc gastric residuals. What do you do? Well, here's some options. Tell the nurse not to bother you at 2 a.m. Stop all feedings. Ask about the physical exam and perhaps examine the baby yourself. Those are some of the options that we had before. But the bigger question is, should we even be checking gastric residuals routinely? Well, we did a prospective randomized study, and this was published in JAMA Pediatrics about 3 years ago. And the title of this paper was Effect of Gastric Residual Evaluation on Enteral Intake in Extremely Preterm Infants. And again, this was prospective randomized in over 120 babies. And the conclusions and relevance in this study was that among extremely preterm infants, the omission of gastric residual evaluation increased the delivery of enteral nutrition, as well as improved weight gain and led to earlier hospital discharge. And these results may translate into evidence-based practice. We also saw no difference in intestinal damage in the 2 groups that were getting the gastric residuals versus not getting the gastric residuals. What about routine meconium evacuation for facilitating feed tolerance in preterm neonates? Well, there have been several studies that have looked at this, and here's a meta-analysis that examined these studies. And the conclusion from this study was that there was very low quality evidence, but giving the enemas or giving these glycerin suppositories did not improve feeding tolerance in the few studies that are available. Now, in the future, we are going to be looking more at personalized nutrition. Why? Well, here we have two babies, a baby born at 23 weeks preterm and the other born at 29 weeks preterm. These are very different little human beings, and their nutritional needs are very different. And we have to begin to think about the fact that one size does not fit all. And if we undernourish or overnourish some of these babies, we could be causing some potential problems. Here's some of these potential problems: NEC, BPD, ROP, late onset sepsis, growth failure. And overnutrition in a baby who's been undernourished may actually result in metabolic syndrome later on in life. So we need to have better ways to provide personalized nutrition for these babies. We use a lot of growth curves, and here's some examples of growth curves. And one of the problems with growth curves is that if the baby begins to fall off the growth curve, it's probably already too late and damage has been done. So what we need to begin to think about is preemptively treating these babies, and how can we use some of the technologies that are available now to be able to provide precision nutrition for these babies so that they don't even have growth faltering, and so that we don't we don't need to play catch-up growth with these babies. Well, we are getting there. And with the use of artificial intelligence and the use of analysis of the microbiome and multiomics, we are getting there. And here's a paper that was published just a couple of months ago. And the title of this paper was Integrating Longitudinal Clinical and Microbiome Data to Predict Growth Faltering in Preterm Infants. And in this study, there were babies that were taken from the network from the UK, and also 3 neonatal intensive care units in the United States. And they integrated data from these different neonatal intensive care units and found features that were highly related to the development of growth failure. And they also found that integrating the microbiome data with certain taxa of microbes, you could predict growth faltering in these babies very early on. So this is one of the first papers using multiomics and artificial intelligence to predict growth faltering. And I think that this will be very important in the future for personalized, precision-based nutrition. And so I'd like to stop the lecture here with some take-home messages. Early nutrition in preterm babies can be safe and efficacious and may prevent significant morbidity. Growth is important, but we also need to consider long-term neurodevelopment and other health consequences. Many of the dogmas that have prevented rapid incorporation of early nutrition have either been disproved, not based on fact, or weak. Not all preterm infants are the same. In the future, we'll need to focus on a more personalized approach that accounts for specific gestational age and degree of illness. And omic considerations such as the microbiome will be utilized for these predictive measures. I'd like to thank you for your attention, and I'd be happy to answer any questions, and I look forward to our discussion.
Thank you very much, Professor New, for that wonderful talk. Just to summarize for this talk, you started with the importance of adequate calories, protein, and fat for TPN, and that we should not be withholding lipids. Start lipids on day 1, because in no other way will you be able to maintain the adequacy of the calories. Then he went on to the enteral part of it and the importance of early feeding, both from the point of view of growth, from the importance of feeding on the liver, and even that it reduces the risk of anemia. And the points of no need for looking at residual feeds, no need for enemas, and to continue trophic feeds during intermedicine, ibuprofen, or even hypothermia. Thank you very much for all of that. I leave the discussion for the audience here. Do anybody want to ask a question? If anybody does, please stand up. They'll bring a mic to that. While they ask, can I ask you one question, please? Do you go for the aggressive protein on day one, starting at 3.5, or would you start at something like 2 grams per kg per day?
This is a little bit controversial, and I am starting at 3 to 4 grams per kilo per day. And I think that there are some papers that suggest that there may be some metabolic imbalances with the use of 3.5 to 4 grams per kilo per day. But I think that it's also important to provide adequate amino acids to these babies. And I think that in the future, we are going to hopefully be able to fine tune the kind of amino acids that are present in the amino acid formulations for providing more precision-based nutrition in the babies. But at this juncture, I think that my tendency is to give more amino acids to these babies, 3 to 4 grams per kilo per day, especially in the smallest babies, because I think that those are the babies who need it the most.
And if so, how much of lipid would you start on the day one?
3.
Right. So 3 grams of lipid and 3 grams of amino acid on day one, right?
Yes.
Any questions from the audience?
We are starting lipid of 3 grams per kg per day in extremely low lipid babies. And we are starting lipid at 3 grams per kg per day in extremely low birth weight babies producing lipemic blood. So what should we do for that?
So I think that this is something that you want to be a little bit careful about, okay? Because that lipemic blood may be not because you are giving too much lipid, but because that baby is so highly stressed. And so we really do not know exactly the reason behind that hypertriglyceridemia, but it could very well be because that baby is so highly stressed and still needs that energy and still needs those essential lipids. So I would, at the very most, just decrease the lipid intake if you are concerned about the hypertriglyceridemia to about 1 gram per kilo per day. But I would not stop the lipids.
Any other questions from anybody? Yes, one more question. Yeah.
So thank you, Professor New, for the wonderful talk. So I have 3 questions. If these extremely preterm babies are extremely low birth weight babies, when they are on full enteral feeds, how should they grow? And what is our growth? What should be our growth target when they reach around 36 to 40 weeks? And how that growth affects long-term outcome? And if poor growth is associated with long-term outcome, what are the nutritional interventions that we can do at around 36 to 40 weeks after that to improve the long-term outcome?
Well, I think that at this juncture, we'd like to have them follow the growth curves, okay? And the growth curves that are standard for your region, there are, I think that there are growth curves that are different in different parts of the world. And I would use the growth curves that you have available to you and look at whether it's a boy or a girl, okay? I think that boys and girls grow differently. And there are certainly sex-related differences that we have to pay attention to. In general, the growth that we like to see is somewhere between around 15 to 20 grams per kilo per day. And certainly if you, I think that poor growth may be associated with poor outcomes at a later point in time. Now, I know that there are some studies, and Dr. Nina Modi has done some studies in the UK looking at certain of these babies. And so, for example, if a baby is born IUGR, there is some evidence that pushing those babies too hard may be problematic. And I agree with Dr. Modi that some of those babies, what you do is follow their Z curve, okay? And what you want to get is a Z, it's not a curve, it's just following their own Z score. And their Z score should be flat, not increasing, but flat. But we don't know at this juncture which babies we should really be doing that with. And I'm hoping that within the next few years, we are going to get a better precision-based approach so that we can look at each baby individually and say, this baby is going to require this kind of an approach.
This one.
Yeah, please go ahead.
Hi, just a couple of questions regarding enteral feeding. I think we all agree that human milk is better than formula in these, especially in these preterm babies. Do you all use banked human milk if the mother's milk is not available? And about fortification of feeds, do you all prefer human milk fortifiers, or do you prefer, do you use whatever is available?
So good questions. Most of the neonatal ICUs in the U.S. follow the American Academy of Pediatric guidelines, and that is that those babies that are less than 1,500 grams get human milk until they're about 1,500 grams. Okay. Now, in terms of whether donor milk actually provides a benefit in all of these babies can be argued. And the reason I say that is that you look closely at some of the studies, I think sometimes we use donor milk and that we sometimes do not adequately fortify that donor human milk. Donor human milk is for these very tiny babies is from a protein perspective, from the various different perspectives, is not adequate for these very low birth weight babies. You don't give them enough calcium, you don't give them enough phosphorus, so they do have to be fortified. What kind of fortification is the best? There are some studies that suggest that the human milk, that the things like the prolacta may be better than giving cow's milk-based fortifiers. I am not convinced that those studies are as rigorous as they should be. And there are studies that are ongoing right now that are not supported by the companies that may tell us those results. But at this juncture, I am not convinced that those human-based fortifiers are necessarily better than the cows-based fortifiers. But there are some retrospective, some small prospective studies that suggest that they may be, but none of them is powered for looking at necrotizing enterocolitis with 1,500 or so babies, which is what is required in an adequately powered prospective randomized study.
Thank you.
There's a question, online question. If a mother is producing milk a lot, can they grade up feeds faster than the 30 ml? You said there a comparison between 18 and 30 ml per kg per day. Can we increase it even faster, say 40 or 45 ml? Is there anything wrong with that?
I think you have to look at each baby individually with that. And I know of some of my colleagues in India who have been doing that at a much faster rate, at 40 and 45. And I think that if it works for a particular baby, I don't have a problem with that. I have seen studies that suggest that it does work. And there are some pioneering studies being done in New Delhi that I think have shown that that is possible. So I'm not going to argue that point. I think it is possible in certain individual babies.
Any other question? No. Okay.
Sir, I have.
Yeah. Go ahead.
Thank you, Professor. We all understand mother's own milk is the best. But in case we are not able to do that, do you recommend for a separate preterm donor human milk banking? Is it okay to feed the preterms with term? And if we are going to bank only on preterm human milk, the increased protein content of the preterm milk, is it okay? Will that not be producing some feed intolerance? What's your opinion on that? Because even using donor milk, we are encountering feed intolerance a lot.
Yeah, I think that is a very common finding that even with human milk, donor milk, that a lot of our smaller babies do have feeding intolerance. And you have to be cognizant, especially in those babies who are getting non-invasive mechanical ventilation, with nasal prongs. A lot of those babies have abdominal distension. You have to make sure that you are decompressing those babies in terms of air in their bowel. So I think one of the questions that you were getting at is, should we be using preterm donor milk?
Should we have a separate banking for that? Do you suggest that?
I do not suggest that. I do not suggest that. I think that adds a level of complexity which is very, very high. And I'm not sure if you're going to get the benefit by using preterm donor milk.
Thank you.
Yeah.
Do you have any more time? Anyone? We can go ahead. Okay. So I think we still got time. If you are okay with that, we can keep asking questions.
Sure.
See, one of the problems in India is that donor milk is available in certain setups, but not everywhere. And there are these companies which market packed donor milk, which is extremely expensive. So if I start a preterm baby or ELBW baby on donor milk, how long do I need to continue with the donor milk? If the mother is not able to produce her own milk, say, should I continue for a week or 2 weeks or 3 weeks? How long do I do that? And when can I go to a standard preterm formula?
Okay, so the guidelines, the European guidelines and the American Academy of Pediatric Guidelines, they focus at around 32 weeks to 34 weeks corrected gestational age, okay? So I think that is what is recommended by the American Academy of Pediatrics and also the European nutritional guidelines. But in terms of the use of the donor milk, my question to you is, when you look at the literature really closely, how convincing is it that donor milk actually is that advantageous for the prevention of necrotizing enterocolitis? That is the reason it's usually given, that it prevents necrotizing enterocolitis. But those are all retrospective studies. And the retrospective observational studies are, those are associations. They are not done in a way that we have a really rigorous way to looking at whether necrotizing enterocolitis is actually prevented by the use of donor milk. So it may be that some of these babies are having less feeding intolerance. And with less feeding intolerance, with the use of donor human milk, we are doing less radiographs that show these findings that could be suggestive of pneumatosis intestinalis, but we see so many radiographs where the radiologists say suggestive of pneumatosis intestinalis, and then we write that the baby has necrotizing enterocolitis in the chart. So I think that we need to take a step back and ask, what is the definition of necrotizing enterocolitis? How do we actually diagnose this? And we need to come up with better definitions of these intestinal injuries that we see in babies. And necrotizing enterocolitis, I think, is not really a discrete disease. It's a diagnosis that encompasses several different entities. So even though we are making some progress in these areas, I think that we are not making enough progress. And one of the reasons is because we have this diagnosis of necrotizing enterocolitis, which is extremely diffuse and not well defined.
Thank you very much. I think we are run out of time. That was a wonderful talk, and thank you for answering so patiently.